Good morning, everyone. How are you? Thank you guys for coming here on a Saturday and spending our day trying to learn a little bit more about the eyes. And thank you, Dr. Masaki, and everybody at the Mini Medical School for allowing me to come and speak. So I'm Mike. For the financial disclosures, I am a medical and a surgical consultant for various pharmaceutical and surgical device companies, some of which we'll be talking about here, but I'm not really talking, it won't sway my talk. I'm talking objectively just about the different types of devices that are out there. And I do participate in clinical trials where we evaluate the efficacy of certain devices versus other devices, but not relevant to our talk that we're having today. So a little bit about myself. I was born and raised here in Hawaii. I went to JABSOM, as Dr. Masaki said, and I'm a proud graduate of the class of 2013. Then I went to Miami for my residency and my fellowship in glaucoma. And currently an assistant clinical professor here in ophthalmology. And so all the students that are kind of interested in ophthalmology from medical school, they come and rotate through us with our practice and come watch us in surgery. And so hopefully we can get them into good programs so they can be my ophthalmologist when I need one in the future. So I'm still stay very active in JABSOM. I'm on the board of directors for the Alumni Association, and I work here at Queens. So it's hard to talk about everything in the eye that kind of took 5 years to learn, but we're going to just try to go to the basics of talking about the eye anatomy that you guys need to be aware of just for your own health and to also understand about what glaucoma is and what glaucoma does to your eye. And then we'll talk about glaucoma. What is it? Why does this matter to you? How does glaucoma affect the average person throughout their life? And what kind of treatment options that we have? Some of the old school methods versus some of the new things that have come out within the past decade that have kind of changed the landscape of how glaucoma is treated. And lastly, we'll do a little question and answer and dispelling some old wives' tales about the eye. So you can think about the eye as a camera. It is very, 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 very similar. We have a lens, just like a lens inside a camera that helps to focus light onto the retina, which you can think of as the film of your camera. Our lens becomes a cataract over the age of 50, and that's what we do cataract surgery on. And like every camera, it has to connect to a computer to download its photos. And so the cable that connects our eyeball to our brain is called the optic nerve. And this is the structure that gets damaged in all the types of glaucoma. So from our eye, light signals travel through this optic nerve, split right here at something called the optic chiasm, and goes to the back part of our brain where all of the image processing occurs. So if you have a stroke in the back of your brain, you can lose your vision. That's called your occipital cortex. And so glaucoma is a chronic progressive disease that damages your optic nerve. It's really confusing when you Google glaucoma because there's so many different types of glaucoma. There's over 20 different types of glaucoma. But the end result of every single type of glaucoma is that this nerve is starting to get destroyed. It's starting to get damaged. And that process is irreversible. There is a common misconception that glaucoma is high pressure in your eye. That's not true. All types of glaucoma are treated by lowering the pressures in your eye. And by lowering the pressure in your eye, you can slow the rate of progression. But the majority of the glaucoma seen here in Hawaii, because of our Asian population, is actually a type of glaucoma called normal tension glaucoma. They had never had high pressures before in their life. Computer analogy. Okay, so why do we care about glaucoma? Glaucoma is the leading cause of irreversible blindness in the world. There's over 80 million people with glaucoma and 3 million in the US. And a lot of people call glaucoma the silent blindness. And why do they call it that? It's because glaucoma, for the vast majority of glaucomas, is not painful. There is one type that can be painful, and that's called acute angle closure glaucoma, but that's less than 1% of all of the glaucomas that we deal with. For the most part, it's painless. And secondly, the vision loss that you get from glaucoma is all in the periphery of your vision. So it'll start out here, and then it'll tunnel in, tunnel in, tunnel in, and then at the very end, it'll take your central vision. And usually that's when the patient comes in, once the central vision is gone. But by that time, 90 to 95% of the nerve is dead already. And it's a little bit too late to start trying to save that vision. It's never, I guess I would say too late, but it's not ideal. And so for the key for glaucoma is to diagnose it early. You diagnose it early, you lower the pressures, and you can slow the rate of progression. So hopefully you can give that person as much time with useful vision as possible. And so who's at risk? So anybody over the age of 50, and especially if you've had a family history of glaucoma. So try raise your hand if you're over 50 in this room. All right. And keep your hand up. Keep your hand up. Raise your other hand if you guys have a relative that, mom, dad, brother, sister, or cousins that have had glaucoma. And so many of you have two hands up. It's very relevant for your eye doctor to be checking for you every single time you go in, because the older you get, you can think of glaucoma as kind of like a wear and tear of the optic nerve. Some people's nerves are designed to live 100 plus years. You'll never get glaucoma. Other nerves are designed to live 60, 70, 80 years. And as you get toward the end of the lifespan of that nerve, that's when glaucoma sets in. It starts to break down. And that process is silent. It's painless. And the vision loss that you get is imperceptible to you to the very end of the disease. There are, again, many different types of glaucoma, but the two main ones that you guys will be kind of learning today is primary open-angle glaucoma, and that's kind of the age-related wear and tear of your optic nerve. And we just talked a little bit about acute angle closure glaucoma, but I'm not going to go over that today. That's when the drainage system of the eye can abruptly get shut. The pressures rise very fast, and that's a surgical emergency. But that's not very common. And so you do not need to know all of the different types of glaucoma. Just kind of try to understand that it's more of in general, a wear and tear of the optic nerve. As we get older, we have to just monitor for it a little more. And so the main takeaway points from this lecture is to gain a basic understanding of what glaucoma is, how it affects your vision, why it's so dangerous, and the treatment options that we have. And so again, you cannot cure glaucoma. It's a chronic, progressive disease that gets worse over time. And the damage from glaucoma is irreversible. So just like any nerve damage in our body, a quadriplegic will never walk again. Once the nerve is damaged and that part is dead, it'll never revive itself. You'll never be able to see from that area of the nerve. So diagnosing the disease early, treating it early, buys us more time with useful vision. And so my job as a glaucoma specialist is to keep you seeing for as long as humanly possible. And every eye is unique. So there's so many, as we mentioned before, so many different types of glaucoma, so many different variations in somebody's anatomy, what their pressures are, how fast they're progressing. So every eye is unique. So every eye is treated differently. So every eye, it's not like 20 people in this room have glaucoma and they're all being treated the same. That's not true.
In the healthy eye, fluid called aqueous humor is made in the front of the eye and flows out through a tiny drain called the trabecular meshwork. The trabecular meshwork is located in an area called the drainage angle. If fluid doesn't flow out of the drainage angle properly, eye pressure increases and damages the optic nerve.
And so this is a picture in the back of somebody's eye, and this highlights what the optic nerve is supposed to look like. So this little disc is the cable that leaves your eyeball and goes to the brain. Ideally, you want a thick pink donut here. All this pink tissue represents the healthy nerve tissue, and the white in the center, that's just the dead space. So you can think of it as the hollow area of the cable going back to the brain. This is an example of what glaucoma looks like as it progresses from your nerve and what you see. So this here is called a visual field. The black areas represent areas that you cannot see. This is a normal visual field, and this black area right here represents our physiologic blind spot. That's where the nerve enters the eyeball, and there's no visual receptors there, so you can't see anything in that spot. And this is a normal nerve with, again, a thick donut and a small center. as glaucoma progresses, that donut, as the tissue loses more nerve tissue, it becomes thinner and thinner and thinner. And as that progresses, it'll tunnel in on someone's vision. And so even here, I see this every month. Somebody that has a nerve that looks like this with over 90% of their vision lost, as long as they can see well in this little vision island that remains centrally, if they're 20/20, they'll come to my office and say, Dr. Yin, my optometrist or my ophthalmologist told me to come here. They said I have something called glaucoma, but I can see fine. And they'll say, like, I see 20/20. I told you. And so they have no perception that this is all gone because your brain doesn't see black in those areas. Your brain will fill in a virtual image of what it thinks should be there. Because you imagine if you were in a box and you just had one little tiny keyhole to kind of live your life out of, you go insane, right? So your brain is very good at adapting to a lot of the deficits that you have. So this is what it looks like, an image simulation of what happens in glaucoma as it starts to progress. And so there's three different ways to lower the pressures in glaucoma. The first and easiest method is using medicines, and it can be as simple as one eye drop at night before you go to bedtime. The second method, and is actually a really good first-line treatment as well for certain types of glaucomas, are lasers. We can do lasers to help to rejuvenate the outflow system of your eye to lower your pressures naturally. And lastly, if you fail medicines and you fail lasers, we can do surgery. And that's one of the things that I specialize in. And so a lot of people call glaucoma specialists the plumber of the eye. And it's pretty simple. If you think of it as a toilet, there are two ways to lower the pressure, right? You can decrease the amount of fluid that the eye makes, or you can increase the amount of fluid that the eye drains. So you can work on the drains, or you can decrease the fluid that's inside the eye. And so there's two main categories of medicines that do that. And for lasers, there's many different types of lasers that we use for glaucoma, but the ones that you and your family members or your friends may have had most likely are these two, SLT and LPI. And a laser peripheral iridotomy is a laser to punch a hole through your iris to prevent the scary type of glaucoma called acute angle closure glaucoma, which can make you go blind in days. So that doesn't, a lot of people come to the office and say, oh yeah, I had a laser for glaucoma maybe 20 years ago, but then that was it. I never, it got cured. That laser just bought time to keep the drainage systems open. So it was just trying to prevent that one single type of glaucoma. It wasn't actually that person didn't really have true glaucoma, didn't have nerve loss. They were just at risk of their drainage systems closing. People that do have glaucoma, the first laser that they'll get is something called a selective laser trabeculoplasty. And in SLT, oh, this music, will numb the eye and will do a painless laser. It takes us about maybe 30 to 45 seconds or so to do this. And we'll shoot a laser into the drainage canal of the eye, and it'll force the eye to remodel itself to open up its drains. 75% of the time, we get a pretty good reduction in pressure, so about a 20 to 30% reduction in pressure. And that can allow somebody to avoid starting or using eye drops, or it can also be used to augment therapy. So say somebody's on multiple eye drops already, and they're intolerant or have allergies to another one, we can do SLT to further lower their pressures without adding more drops to their regimen. And so the last resort is surgery. So if medicines and lasers weren't able to work, then that's what we're here for. So there's two main categories of surgery. When I was in training, the main category of surgery was our traditional kind of big gun glaucoma surgery. That included two things. One is called a trabeculectomy, and one is called a tube shunt. And now, within the past decade, there's been a huge explosion in the realm of what we call minimally invasive glaucoma surgery. It's a way to optimize the drainage systems of your eye in a much more minimally invasive, safer way with decreased risks of complications. And I'll kind of go through the big reasons why this is kind of now there's been a paradigm shift as the standard of care early on in your glaucoma journey, if you will. So for the traditional glaucoma surgeries, they have the highest efficacy, but because they have the highest efficacy, they have the highest amount of risk. So the risk that you can have a potential complication that can make you go blind, the pressures could be too low, and too low pressures, believe it or not, is actually worse than having higher pressures. And so in general, traditional glaucoma surgery is used as the last resort when everything else fails. So a trabeculectomy is depicted here. So what we do is we remove the skin of the eye. We'll cut down a scleral flap here. So 90% of the thickness of the eye, which is about a little less than 1 millimeter. And then we'll tunnel in and we'll actually use something called a Kelly punch, which looks like a hole puncher, and punch a hole in the periphery of your eye and close everything back up. And then fluid will then leave from the front of your eye under the skin of your eye on the top, and that kind of acts as an extra drainage conduit. The surgery, big in glaucoma surgery that I do more often is a tube shunt. So we'll remove the skin of the eye temporarily to access this space. We'll have a shunt that we sew onto the eye about 7 millimeters back. And then there's a tube that runs from that shunt and we'll thread it into the center of the eye. So again, establish another drainage system to lower the pressures inside the eye. And then we'll close everything back up. And you won't be able to see this surgery in somebody that's had the surgery. The eyelid will cover it. So this is an example of me in residency just doing a trabeculectomy. So I'll do a traction suture here so I can control the eye, and I'll inject a medicine that'll prevent them from scarring down. I'll open up the drainage systems of their eye and cut a partial thickness scleral flap, and I'll dissect it all the way to the cornea, the clear portion of the eye. And then that's the hole punch. And then we stitch everything back up together. And then make sure the eye is closed watertight, because if there is a leak, their pressures will be 0 on post-op day 1, and you have to take them immediately back to the operating room if that happens. And their eyelid will cover that area, so you won't be able to see that. But you can see, ideally, you don't want that, right? There's so many other things that you would want other than that. So that's why it's one of the last resorts. And this is a tube shunt, again, probably me in residency or early in, yeah, this is me in residency as well. So we open up the skin of the eye. We'll go between the eye muscles and we'll stitch this implant on. And then we'll thread a needle into the eye for the tract of the tube. And that tube will then drain fluid from the front of the eye over the plate that we sewed on and lower the pressures. And then again, we close it, making sure that it's nice and watertight. But there's a lot of long-term complications to this. So if you're getting this at, say, age 75 or 80, the likelihood of you kind of living toward the long-term complications is a lot lower. But say you're 50, say you're 45, and you're needing something like this, there's a piece of plastic in your eye, and that has consequences. Over time, it degrades certain portions of the eye that can require you to have a corneal transplant. The tube itself can erode, so the skin over your eye is very thin. So over time, that can erode, and we may have to take out that implant and put it in a different area, which is a very big surgery that ideally you don't want. So everything about glaucoma management is about buying time. As much time as we can buy you before you get this thing, the better. The better the long-term health of the eye. And so now enters the era of minimally invasive glaucoma surgery. And so even when I was in residency, by the time I was in residency, which is 4 years for ophthalmology, but minimally invasive glaucoma surgery was not commonly performed as one of the first or second line therapies for glaucoma. But by the time I hit my fellowship, which is my 5th year, it was already exploding that realm of minimally invasive glaucoma surgery. They realized that it was much safer, and then the outcomes that you can get are sometimes as good as those traditional glaucoma surgeries. But again, every glaucoma patient is unique, and not everybody is a good candidate for this. But looking at the size of these devices, you can see just how small they are inside the eye and how much safer their safety profile can be. So why do MIGS? It's safer. It can lower the eye pressures, sometimes just as much as the traditional glaucoma surgeries, but on average, a lot less than those big traditional glaucoma surgeries. Um, it's a lower rate of complications, so definitely makes it safer for the eye, and mainly it can buy you time before you have to get a traditional glaucoma surgery, or it can buy you enough time. So again, our job is to have you with a lot of useful vision for the remainder of your life, right? You don't have to have 100%. Even if you have 70 or 80% of the vision, that's not visually significant. You won't even notice that vision loss. It's not something that you would notice from a day-to-day life perspective. And so there's so many different types of minimally invasive glaucoma surgeries. I'm just going to go over some of the most common ones that we do. So, you know, don't focus on which one is right for you. That's the job of your surgeon. It's not a one size fits all, as we were just talking about. Some MIGs are better in certain types of glaucoma than others. And so the three that I'm going to discuss today are the Omni, the Hydrus, and the iStent. And so, again, kind of reviewing that the eye is like a toilet and I'm like a plumber. Basically, we can decrease the fluid or we can improve the drainage system. So the whole point of the minimally invasive glaucoma surgeries are to make better drains, to either optimize the drains that you already have or make a new drain minimally invasively. And so we're working on this area here. I don't know if you remember from the video, but your eye is constantly making fluid from back here. And that fluid helps to nourish the eye, keep the eye healthy. And we need that fluid for the eye to survive. So because we're constantly making fluid, we constantly have to drain fluid. And that becomes the problem when you have glaucoma. And so this area here is like the gutter system inside your eye. It's called the trabecular meshwork, and it guards the fluid from leaving the eye into the drainage systems, which are the blood vessels. So the device that I most commonly use is called the Omni device. What we'll do over here is we'll go behind that thin membrane of the trabecular meshwork into a potential space called Schlemm's canal, and we're going to dilate it, essentially like rotor-rooter of the drainage system of your eye. And then I'm going to inject the fluid as my catheter leaves, kind of to throw Drano down the drains, which are the blood vessels. So, and then I'll re-enter the eye, and then I'll unroof that trabecular meshwork to remove that gutter system in certain areas to keep it open long-term. So you'll see here an animation of us going through into the gutter system. This is the rotor-rooter. And as this device retracts, it injects fluid, or a jelly, if you will. And that's the jelly, that's the Drano. So it optimizes three different points of the drainage outflow system. I'll go back in and then remove some of that membrane, because that membrane could just scar down later on in the future. And that just highlights how the fluid can then more easily leave the eye. And this next device is called the iStent. It's actually the smallest implantable human device that we have. And this stent goes through that trabecular meshwork into that potential space to kind of bypass the gutter system. But looking at how small that device is, you can see that it's not, or its potential efficacy is nothing like the Omni device that you just saw, where you're removing the meshwork in its entirety. So this is me doing a combination. I combine MIGs as well. So it's not just using one, you can use several. So this is me doing the Omni first. So this is right after somebody's cataract surgery. I'll then do the glaucoma portion. So that's me entering the canal. And then as I retract, it opens up the drainage system by shooting out that jelly. And then that was the inferior 180 degrees. And then I'll do the superior 180 degrees here. And I'll come back out. And before I completely come back out, I'll re-engage the catheter and then rip out the trabecular meshwork up top. And to further stent open the drainage systems, I'll do the eye stents. And it's kind of like playing a video game. You go in there and you press a button and it shoots out. It's super fun. This is like the best part of my job. The last stent that we'll talk about is the hydrus. So the hydrus is a scaffold that will go behind that trabecular meshwork, behind that gutter system, and keep that canal open long term. And as you can see, it's much bigger than the eye stent. The eye stent would be like the size of just this tip. It'll allow 90 degrees of your drainage system to stay open long term. So this is us just inserting the hydrus into the drainage system. And you can see it's much bigger than that eye stent, and that'll stay there long term. And this is a combination of me just doing both an Omni and a hydrus. So again, for the Omni, we're going behind the trabecular meshwork, doing that rotor-rooter. And that's creating the space where I will insert the hydrus at the end of the case. And then I'll go to the opposite side and do the rotor-rooter on the superior drainage system. And then remove that gutter system. And then place the hydrus device in the bottom. And that'll be left long term. And all that's under 10 minutes too. So it's super fast. It's such a efficient way to lower somebody's pressure. And we both do the minimally invasive glaucoma surgeries at the time of your cataract surgery. So your cataract surgery would be anywhere from like 6 to 8 minutes. And then this will be just add on about a minute or two on top of that. And so also, if you've had cataract surgery in the past, easy, we can go through that same wound that you had your cataract surgery from. It's just a 2 millimeter incision, and then do the minimally invasive glaucoma devices. So in summary, for the minimally invasive glaucoma surgeries, there are so many different options available to you, and it's not a one size fits all. Just if you're getting cataract surgery, if you had cataract surgery, or if you have a friend that's going to get cataract surgery, it's worth asking your cataract surgeon, if you do have glaucoma, do they do MIGS? What MIGS are they comfortable doing? What do they know about? Are they a general ophthalmologist, or are they a glaucoma specialist? And just getting a educated opinion prior to that person doing the surgery, I think it can be very, very, very important. Although MIGS can be a lot safer than traditional glaucoma surgery, unfortunately, not everybody is a good candidate for minimally invasive glaucoma surgery. There are types of glaucoma where the drainage system is scarred down, and there's the brown portion of your eye, or green or blue, called the iris, can be stuck to that drainage system. In that case, that's called angle closure glaucoma. And unfortunately, they're not a candidate for most of those minimally invasive glaucoma surgeries. So just kind of having an understanding that, hey, not everybody may be a good candidate. So if your surgeon tells you that, oh, we can't do it for X, Y, and Z, then there's usually a good reason. And MIGS can delay, again, it can lower your pressures and delay the onset of hopefully you needing a big type of glaucoma surgery, which you saw before, which ideally nobody wants to get because of the complications rates that happen 5, 10, 15, 20 years down the road from that surgery. And key points to summarize: you cannot cure glaucoma. It is an irreversible disease that will progress through the course of your life. And the key for it is just lowering your pressures, slowing down the rate of vision loss. As long as you diagnose glaucoma early, you treat it early, and especially if you get it in the mild stages and you start treatment, 90% of people will not go blind during their lifetime. So just being aware of it, screening for it, looking for it, and treating somebody early can help save their vision over the course of their life. And there's so many different great options to treat glaucoma: medicines, lasers, and surgeries. Um, ooh, fun. So dispelling old wife cells. Don't look at your pamphlet because I think all the answers are there. So true or false? Sitting too close to the TV will ruin your eye. My mom told me this every day when I was a child. True? Anybody? True? Yeah, some choose. False. So false. You totally can. That's not going to damage your eyes at all. Your vision will get worse if you read in the dark. My mom also told me that. False. Again, it's just harder to read in the dark. So wearing glasses will make you dependent on them. Some actually, even now, some of my patients say like, "Oh, I kind of don't want to wear my glasses, and I want my eyes to get worse." So it's actually a fair question. This is a hard one. True? False. Yes, agree. If you wear the glasses, you just have better vision. So your eyes will progress regardless of that. But I will say one caveat is for kids. So anybody under the age of 12 and especially under the age of 8, they have to have the correct prescription. If they don't, their brain will learn to ignore the bad eye and focus on the good eye, and that's called amblyopia. They'll develop a lazy eye. So kids have to have the correct prescription. After you're 12, it doesn't matter. So wearing glasses with the wrong prescription. Oh, sorry, this was also with the kids. Oh, well, I kind of answered that one for you. Sorry. Yeah. So wearing the glasses with the wrong prescription will ruin your eyes. Absolutely not. It's just going to be more blurry. So just get a better prescription. Yeah. But for the children, you got to make sure that they have a good pediatric ophthalmologist. And eating carrots will make your eyesight better. So it won't affect your eyesight sort of indirectly, but yes, carrots have vitamin A, which are essential for the functions of your retina. So yes, you do need vitamin A. It won't improve your vision, but it'll keep your vision nice and healthy. So thank you again, Dr. Masaki, for having me, all of you guys for being here. Any other questions? Yes.
Well, could you hold for 1 minute, please? We want to make sure we have the mic.
Oh, I'm sorry about that.
Everybody can hear.
Could you mention a little bit more about steroids?
Yes, that's a really good question. So steroids, both systemic, meaning you're taking a pill for steroids, and steroids applied directly on your eye, have a risk of raising the pressures in your eye, especially for chronic steroid use. And what I mean by chronic is somebody usually on steroids for over 3 to 4 weeks. So a steroid, we call it a steroid response, where the pressures rise. It is very rare to have it under 3 or 4 weeks. So say you get a cold and your doctor prescribes you a Medrol dose pack of prednisone, and that lasts usually for 5 days. You're like, and especially if you have a glaucoma, don't worry that short amount of steroids is going to raise your pressure. But in general, 10% of the population are what we call steroid responders. When steroids hit the body, and especially when it affects the eye, for some reason, it blocks that drainage system inside the eye, and it can raise the pressures in 10% of people. And it turns out that a high percentage of people that have elevated eye pressures during a steroid course, those are the people that end up well, not all of them, but a high percentage will end up getting glaucoma over the age of 50. So if you are a steroid responder, that is another risk factor for you to tell your doctor, say like, hey, I was on steroids before, my pressures were high, and making sure that they're monitoring your nerves for changes for glaucoma. So say you're on steroids for 2 to 3 months or something, or sometimes people are on it for years. If your pressures rise, that's okay, as long as your eye doctor can medically decrease the pressures in your eyes. They can give you eye drops, they can do lasers. That's okay, as long as your pressures are being monitored, that's fine. It takes, in general, the amount of time that it took to rise, so usually about a month or so, for your pressures to come back down. So say it took you a month for the pressures to rise, After you stop the steroids, your pressures will still likely be high for another month, and then they'll start to drop. So there's a delay in the response. It's a remodeling of the drainage system that has to occur. It's a good question. Anything particular about steroids? And so that arises another type of glaucoma, steroid response glaucoma, which is a very treatable and potentially curable type of glaucoma because if you think you just don't do steroids, the pressures won't rise.
Thank you, Dr. Yim. We're going to alternate between our online and in-person
Sure.
audience. Yeah. Just a fact, one of the participants online say you are performing his cataract surgery on Thursday. So it's a coincidence.
Hello.
And just to let you all know, we are having Dr. Yim come back next year to talk about cataracts. So come back in 2025 and we'll have Dr. Yim again. Thank you, Dr. Yim.
You're welcome.
Okay. The question that we have here is for glaucoma surgery. Do you do both eyes at the same time or only one eye at a time?
Oh, that's a great question. So we'll do one eye at a time. And for pretty much any eye surgery, we'll do one eye at a time, cataract surgery or glaucoma surgery to make sure that the eye heals well and then go again. So it's logistically hard too. So say you had glaucoma surgery in both eyes and you just can't really see well in both eyes for the next several days. Your risk of falling, your risk of hitting something accidentally in your head, it's not, we'd rather have one good eye, do the surgery, have that recover, than do the other good eye.
Makes sense. Thank you.
Yes.
I have my right eye gets wet throughout the day. My ophthalmologist said there couldn't be nothing could be done about it. Another ophthalmologist said to take
Artificial tears.
no, it's that allergy eye drop.
Yeah. So I would ask, is it painful?
No, it's not painful. It's just like like a tear, looking through a tear.
So that's a condition called epiphora. And that's actually a lot more common over the age of 50 and 60. So actually a lot of people may end up dealing with that in the future. There's three big common causes for epiphora, or the excessive tearing. And so number one, the most common cause is your eye being dry. When your eye is dry, your body tries to self-correct and make more tears. So it'll produce its natural artificial tears and it'll tear more. But usually people that suffer from dry eyes, they complain about intermittent, what we call foreign body sensation. So feeling like a little rock or a hair is inside their eye. Sometimes they have some burning sensation. They'll have fluctuating vision. When the eye is dry, your vision's a little bit more blurry. Doesn't sound like that's likely what's going on in you. There are two more anatomic things that are quite common as we get older. As we get older, our skin changes, and our eye, the surface of our eye has skin, as you saw me remove in those glaucoma surgeries. The skin becomes to, I guess, bundle up like this, and it affects the flow of tears from your eye into the nasal cavity, the nasolacrimal duct. So if you have something called conjunctival chalasis, that's the buildup of the extra skin, your tears are just rolling over the lid of your eye instead of draining right here where it should be. And that's surgically correctable. We can just cut out the redundant area of the skin, and that can be controlled. I haven't examined your eyes, so I don't know if that's the case. And if that is not the case, what your doctor can do is something called a dilation and irrigation. And it's just in the office. They'll numb your eye, and then what we'll do is we'll dilate the drainage system. You have two drains called the punctum on the upper lid and the lower lid that drain your tears. We'll dilate those areas, and we'll stick a little syringe down, and we'll kind of irrigate fluid. If you cannot push the fluid through and you don't feel it on the back of your throat, then you know that there's a blockage in your nasolacrimal duct system. So there's a blockage from your tear flowing. And so that can also be corrected for. We'll send you to an oculoplastic surgeon where they can stent it open, or they can do kind of a big surgery called a DCR, where they'll drill through the bone and then put a Pyrex tube in to kind of drain your tears. I don't recommend people do that, especially if it's not bothering you. I would say the long-term risk of that implant getting an infection or extruding as you get older. It's not high, but it's not low, you know. So there's a lot of different causes and things can be done. Did he or she dilate and irrigate the drainage system of the eye to figure out where the blockage is?
Well,
Yeah, did you get the dilation and irrigation to see if it was a nasolacrimal duct
no,
obstruction?
no,
Okay.
no.
So I would ask if your ophthalmologist is comfortable doing that procedure to do that. And that's an easy way to see if the drainage system is blocked. Because as we get older, the pipes in our bodies get smaller, our blood vessels, the things that drain our eye, and also the things that drain our tears.
I see. Well, all I do now is just dab it with a Kleenex.
Yeah, and if that's working,
And
you know, it's okay.
it's okay. I guess I'll just live with it.
Yeah, but you could get an answer to your question.
Thank you.
You don't have to follow the treatment for it, but sometimes it'd be nice just to know exactly why. Yeah.
Thank you.
You're welcome.
Can you explain the treatments to lower pressure? You mentioned that many Asians have glaucoma without high pressure.
Mm-hmm. Oh, yeah. So I guess so. Those are two questions. So number one are the different ways that we lower pressure. So number one, medicines. Number two, lasers. And then number three, surgery. And there's different mechanisms within those three categories that can lower the pressure. So we can make less fluid or we can work on the drainage system. And the second question is the majority of people, at least that I see in my practice here, have what we call normal tension glaucoma. So there's many different types of glaucoma. When you're on the mainland, when I was in Miami doing my residency, my fellowship, the vast majority of patients were what we call high pressure POAG. So their normal pressures are 21 and under. And so these people in Miami, they tend to present with pressures like 30, 29, 28. They had no idea. They're just kind of coming in for a routine glasses check. And then we like, oh, wow, that's a very easy way for us to screen and say, okay, you have glaucoma. Here, a lot of people have pressures of 14, 15, 16, sometimes even 10. And then when you look back at their optic nerve, you can see that a lot of it's already destroyed. And so they've never had high pressures before in their past, but their nerve is kind of reaching the end of its kind of pre-programmed life that it was born with. And a lot of that was genetic, right? That's not something that they did bad during their lifetime. You can think of it kind of like dementia. You know, some people get dementia, some people don't. We have no idea exactly why. We have some genetic markers that increase risk and whatnot. But when the brain reaches a certain level in certain people, it starts to degenerate. Same like the optic nerve. And so being able to catch that with your annual eye screening, that's super important. So it can fool you if your eye doctor was just checking the pressures and not looking at the back of the eye, because a lot of would say politically correct here, but sometimes the optic nerve is not always evaluated. And it depends on when that person trained, what their level of comfort is in evaluating that structure. You would think that everybody would do that every time, but that's not the case. So just making sure that your nerves are getting evaluated, the nerves of your family members are getting evaluated every time you get dilated. That's important.
If you've had a history of high blood pressure, well, both high blood pressure and eye pressure, because of I obviously attribute it to my job, but now that I'm retired, my pressure is low. So I'm now being monitored and taking medication for eye pressure and field of vision. So my question, though, is what's more important at this time? Do I ask about my field of vision and has it changed? Or will the pressure automatically say it's time to go see a glaucoma specialist?
So, nice question. So there's several questions there. One, I think you were talking about is the relationship with high blood pressure and high eye pressure. So while there is, I would say, a minute relationship, they are very independent of one another. So regular blood pressure is 120 over 80. Say you had 120 over 80 and your pressures were, for simplicity's sake, say 20. Okay. Then the next day something happened and your blood pressure is 220 over 110, like almost a doubling of your blood pressure, your eye pressure would go from 20 to 21. So although you can have an elevation in your eye pressure, they're very much unrelated. So the likelihood of your pressures in your eyes being more well controlled, that's likely because of the medicines that you're on. The blood pressure, exactly, that's a lot due to stress, aging, our health, our body, our physical fitness. So I would say that they're two very independent things. Your eye doctor who's monitoring your visual fields and your pressures, they should be letting you know if there's progression, because if there is progression, you'll be starting new medications or doing a laser or doing new therapies. Every time somebody with glaucoma progresses, the target lower, something has to be done. Your pressures will then be lowered by a target of about 20%. So they'll look at, and that's why we see glaucoma patients so often. We see them about 3 to 4 times a year, as long as they're staying stable. Your pressures are dynamic inside your eye, just like your blood pressures. They'll go up, they'll go down, they'll go up. So if I see you at 8 a.m. versus I see you at noon, your pressures will be different. So we're just catching you 3 to 4 times a year at one specific time. We don't know the true fluctuations. We don't have the manpower to see it like every week, right? And so we need the average of your pressures. And say your average the last like 2 years was, say 20 again for simplicity's sake, and then you progress, the visual fields got worse. Your new target pressure every single time you come in should be 16 or below. And so how they accomplish that is up to them, right? They can do a laser, they can do drops, they can send you for surgery, but they'll do everything in their power to then lower you, but they should be lowering you, which again, not everybody does. So just make sure that if your glaucoma does progress, make sure like, okay, what's the next step? Just ask your doctor. Yeah.
If the tear ducts are blocked, is that the same drainage system that causes glaucoma?
Oh, that's a great question. Totally separate. Tears, everything external on the eye, drain through a total different system from everything inside your eye.
So I had cataract surgery last winter, and I thought I was really moving right along.
Sure.
Until I came here today.
Okay.
And so the last thing they asked me was, well, who's going to take care of your glaucoma? And I said, well, I guess I'll go back to my optometrist. But now I think I need to go somewhere else. So what would you recommend for somebody like me who really was totally not clued in?
That's a great question. So I would say that there are, I would ask your optometrist, number one, do they feel comfortable managing your level of glaucoma? Because not everybody that has glaucoma needs the specialty of a glaucoma specialist, right? If you have mild, well-controlled glaucoma, you may not really need or have that much of a benefit coming to see me, right? But that's a fair question, right? To ask them like what your stage of glaucoma is. Do they feel comfortable? Have your pressures been well controlled? Do you know what your average pressures have been since the cataract surgery? Oh, okay, gotcha. Okay, they don't talk about the pressures on your visits? Okay, so maybe just kind of getting an idea as well of what your pressures are. Again, normal pressures are under 21. People that have glaucoma at various stages, again, everybody has a unique pressure goal based on their eye, their rate of progression, what's happened, what levels of pressures they've progressed at. So that should be unique to you, that your physician should know. Ask them what your target pressure is, and if you're on their target, and just kind of take your health into your own hands and try to figure out what your pressures are. If they don't feel comfortable, then ask them to send you to somebody that can manage your glaucoma. And certain optometrists, will be very frank. I co-manage with a lot of different optometrists. They don't want to deal with glaucoma. I'll see them for all of their glaucoma checks, but they'll stay with their optometrist for their annual eye exam, their glasses check, their dilated eye exam, and vice versa. Some people that don't feel comfortable with glaucoma say just you deal with it. You deal with everything. I don't want to deal with that. But I will say that there are some optometrists that are phenomenal, and they're just as competent as, say, like the best general ophthalmologist, that can handle the majority of types of glaucomas. And again, there's ophthalmologists that are good. There's ophthalmologists that are not as knowledgeable in glaucoma, and there's same with optometrists. So I would say asking your optometrist would be pretty fair place to start.
What is the mechanism by which eye drops lower eye pressure?
Yeah, so that's a great question. So each eye drop there's 5 different categories of eye drops, but you can think of them simplistically as working to either decrease the amount of fluid that your eye makes or increasing the drainage capacity of your eye.
At what age do you no longer recommend glaucoma surgery?
Oh, there's no cutoff. It all depends on the patient. So, for example, that's a really good question. So, say somebody is say somebody is 84, highly functioning, comes in without a walker, has not had multiple heart attacks or stents and that kind of stuff, and your life expectancy is maybe 10, 20 more years. You're not in all right, you're too old to do surgery category. We try, again, our goal is to keep you seeing as best as we can for the remainder of your life, however long or short that may be, right? I know nobody's guaranteed tomorrow, but say you have a 50-year-old, poorly controlled diabetic, had a heart surgery already, they had multiple strokes, they still can't control their blood sugars, and their life expectancy is, say, not over likely 2 years or so. You're not going to be aggressive in managing that 50-year-old because of that whole situation, right? But say somebody that's 84, even 90. I have so many patients that are over 100 in my clinic. Everybody lives forever here in Hawaii. Asian women too. You guys live forever. Literally have so many patients that are over 100. But as long as they're healthy, as long as they're functioning, say the glaucoma is progressing at a rate, well, it'll make them blind or not being able to function at home and they live alone. You want to do everything you can in your power to allow them to maintain that independence, to keep their vision as long as they want. Again, versus the 50-year-old that has a lot of these health problems. Eyes, it's not the number one priority. You know what I mean? In general, when we're kind of having that decision of whether or not to prioritize the eyes versus other parts of the body, in general, I'll always defer more toward, you got to stay alive. You can live a very good life being blind in one eye or even being blind in 2 eyes, but you can't live any life without your heart or without your brain. You know what I mean? That's a good question, though. And that's one that we think about for every single glaucoma patient, for sure.
I have a question regarding lutein.
Oh, yeah.
Do you recommend it?
That's a great question. So what she's referring to, lutein is one of the main ingredients in something called AREDS. So the AREDS 2 vitamins are the treatment for macular degeneration. And so lutein is an important molecule that is maintaining health in our central retina, in our macula. That's what we use for our central vision. And so supplementing the macula of a diseased macula, we know that taking the AREDS vitamins decreases the risk of somebody with macular degeneration from converting from the good form called dry macular degeneration to the bad form called wet macular degeneration. However, there's no data that shows that lutein, zeaxanthin, vitamin C, zinc, the other components of the AREDS 2 vitamins can prevent somebody from getting macular degeneration, right? So there's no preventative data yet. That's not to say that it's not good, right? There just hasn't been any well-powered, big enough studies to show a justification for every single person to be on it, right? Because if there was good data showing that this vitamin helped to prevent macular degeneration or maintain eye health, it'd be mandated that everybody take it. So I would say that if you're worried about if you have a family history of macular degeneration, if you have certain lesions in the macula that may be precursors to macular degeneration, absolutely no harm in taking them. And there could be a potential benefit there, but just based on the evidence, I can't say or recommend everybody kind of take them. But I would say as long as it's not impacting your life, there's no downside.
Are there any activities or foods to avoid to slow progression of glaucoma as much as possible? For example, should you not do yoga with headstands or lifting weights?
That's actually a really good question. So get that actually almost every day. Very good question. I would say for the majority of people that have glaucoma, just live your life. I will prioritize your aerobic fitness over transient elevations in pressure. And so what they're getting at is when you are inverted, the blood rushes to your head and it makes it harder for fluid to drain inside your eye. Same like when you're squeezing like this, you're lifting heavy weights, your pressure in your eye can transiently elevate. And so people that have they're kind of like really severe glaucoma, kind of near blind, maybe try to avoid those things and do low impact aerobic activities. But the vast majority of people that have glaucoma likely will have no impact in them. Now, I did have an aerial yoga instructor that had bad glaucoma. She had to change careers. You know what I mean? There are people as well that are deep sea divers that work on the cable systems that connect our internet and everything. I didn't even know that was such a common profession, but they're at depth sometimes for a week at a time, and they actually live under the water. It's actually really cool. I didn't even know about that. But those people, absolutely, they need to change profession too, because their eye pressures are higher. But for the vast majority of people, you prioritize the likelihood of you dying from a heart attack or a stroke is way higher than you going blind from your glaucoma for the vast majority. Yeah.
I think we have one last question. We have lots more online, but we don't have the time.
Oh, yeah, sure.
Thank you for taking mine. I take eye drops every day, every night before I go to bed. But I wondered, you mentioned that the eye drop itself has, it eases the pressure. What, is there too little eye drop, or if you think you didn't get enough eye drop in?
That's a great question.
So
you're on likely a drop called latanoprost, a prostaglandin analog. So that medicine, it decreases the eye pressure by opening up the drainage systems inside your eye. And fun fact, when you put an eye drop in, after your first blink, 6/7 of the eye drop leaves your eye. So only 1/7 of the actual eye drop remains, and that's all you need. The second question is, can I put another eye drop in if you think that you didn't get enough? Absolutely. So once you put the eye drop in, having any amount of extra, that's okay. You're not going to absorb a lot more extra. So now if you were dosing it within kind of like every 10 to 15 minutes, that's kind of counts as a little bit extra because your eyes get a dose, it washes everything out, then it gets another dose and then wash everything out. Then that's not good. And for prostaglandins, latanoprost in particular, they did to bring it to market, they did clinical trials looking at the efficacy of once a day versus twice a day. And twice a day was actually less efficacious than once a day. So for that one in particular, don't dose it on multiple times. But if you miss your eye, absolutely, within 5 minutes, put as much of that thing as you can. You blink out most of it. So, yeah.
Thank you.
Thank you so much, Mike. That was amazing.